Hello, everybody. Welcome to the overview of inpatient medicine. This is part of SHM series on onboarding providers who are working in the hospital, specifically during the COVID pandemic. My name is Tyler Anstead. I'm an assistant professor at the University of Colorado, Anschutz Medical Campus, and I'm delighted to be presenting with Dr. Megan Brooks, who works out of the Duke University Health System. So to start off, we have no disclosures. And here's what we're going to cover in the next 25 to 30 minutes. We're going to cover a broad overview of inpatient medicine. We're going to apply that broad overview to admission, daily care, and discharge. And finally, we're going to go through a few case studies to really emphasize where this can be applied within the hospital system. So our learning objectives really mirror that of the agenda. So describing those three objectives of inpatient medicine, applying the objectives, and then finally, preventing harm, because we all know that hospitals are dangerous places for patients. So I'd like to start off with a quote from a seminal article that actually defined what a hospitalist is, and by Drs. Wachter and Goldman. And really, this quote emphasizes that the inpatient setting is a place where care can happen very quickly with an intense use of resources. However, those resources are also put patients at risk. And so judicious use of resources is one of the most important things that we can do. So the three objectives of inpatient medicine are summarized here. Really, acute condition diagnosis and management, preventing harm during the hospitalization, and progression to the next phase of care. So let's dive in. For acute diagnosis and management, we think of triage, stabilize, and treating the patient. For preventing harm during the hospitalization, we like to say that the safest hospital bed is an empty one. You have all seen the patient safety data that says that really 1 in every 10 patients are harmed while receiving care within the hospital. And adverse events due to unsafe care across the medical spectrum is one of the top 10 leading causes of death and disability across the world. So again, the safest place for a patient, we believe, is at home, not within the hospital bed, once they're medically stable to be there. And finally, progression to the next phase of care. This ties in with the patient safety theme in that we want to get patients home as soon as possible, and to do that adequately and efficiently, discharge planning really should start on the day of admission. Let's apply these objectives of inpatient medicine to the tasks of admission, rounding, and discharge. So on admission, for acute diagnosis and management, really the most important things are triage, stabilizing, and treating. So for triage, you want to determine what is the level of care that is most appropriate for the patient. Is it the medical floor? Is it the ICU? Now, often this is more determined by nursing expertise and nursing burden of care than it is on the actual physicians. Many hospitals, including your own, likely have guides for where patients should be triaged. And oftentimes the emergency department does a great job at this, but it's important to reanalyze when you see patients to make sure that the level of care is appropriate for that patient's condition. The next thing is stabilizing the patient. So you're not always going to be able to get definitive treatment started immediately. It's important to stabilize the patient, meaning initiating therapies as soon as possible and making contingency plans in case those initial therapies don't go the way that you think they're going to. And then finally, treating the patient. Getting collateral information here is really one of the most important roles of the hospitals, getting PCP records and other collateral information to understand who is the patient at their baseline and how far off are they. And finally, calling consultants if needed for those definitive therapies and calling them early. And this is a theme you'll see recurring through all of these objectives. To prevent harm during the hospitalization, another recurring thing is medication reconciliation. Medications are some of the most dangerous things that we do for patients in the hospital. So it's really important to ensure that you know what medications patients are taking at home so that you can decide what needs to be continued on the inpatient side. So use the resources available to you. Some hospitals have pharmacists or pharmacy techs that can track down this information, call pharmacies. Again, use the resources and don't do all the work yourself. And then when deciding which medications to continue or stop, be thinking about upcoming procedures. Maybe you want to hold their chronic anticoagulation, and also be thinking about the potential for withdrawal. In general, we try to avoid sedating medications in the hospital, but if a patient's been taking the same sedating medication every night for the last 5 years, there's a huge chance of withdrawal there. So you have to weigh the risks and benefits of continuing or abruptly stopping a medication. And then finally, preventing harm, you want to think about prophylaxis. This does not only fall into venous thromboembolism prophylaxis, but also think about sleep hygiene, particularly for the elderly patients, and mobilization. It's incredibly easy for patients to get stuck and not move within the hospital. Therefore, it's really important to make sure that those orders and you're communicating with your nurses that it's really important, because we know that that shortens hospital stays. And finally, progression to the next phase of care. As I've already mentioned, discharge planning really starts on the day of admission. So when you're seeing a patient for the first time, you really want to assess who they are outside of the hospital and determining what is their ability for self-care. That includes mobility, access to their medications, and access to nutrition. And finally, assessing their support system at home. So this is a place where it's really important to contact family, again, to get more collateral information of who that patient is. What does their home situation look like, or do they even have a home? Because that's going to determine when they're safe for discharge. Now let's pivot to rounding. Again, circling back to acute diagnosis and management, your job is to really triage patients really every day and determine what level of care continues to be appropriate. Maybe they don't need that ICU or that ICU step-down bed anymore. Maybe they are now floor appropriate because they've gotten better. Or maybe they're getting a little bit worse and they need a little bit more nursing care or monitoring. When we think about rounding order, we advise you to follow the 3 Ds, and those are DIARS, discharges, and decisions in that order. So patients that are acutely ill, those are your DIARS, those are patients that you want to see first. Next are the discharges, and we'll get into why that is in a second. And then finally, prioritizing patients that need decisions for advancing their care. Finally, we also want to emphasize that calling consultants early for those definitive therapies is really the best way to treat patients adequately and efficiently. Next, preventing harm during the hospitalization. Again, this theme of medication review. Just because you've ordered a medication doesn't mean that the patient is actually receiving it. Also, because there are multiple people working within the hospital system, including your night cross cover, make sure to look at the medications every day to identify if anything has been omitted or added. Perhaps there's a medication that a patient shouldn't be receiving, but was ordered overnight during a busy cross cover shift. And finally, you want to continue to assess their function. So are they mobilizing, like you put in the orders to do or ask them to do? Are they sleeping? Are they eating? Are they using the bathroom adequately? Because that'll determine if the patient is ready to leave. And then finally, progression to the next phase of care. Again, we emphasize the 3 Ds of DIARS, discharges, and decisions. This is where the discharge really comes into play. We strongly advise that you discharge your patients as early as possible because the discharge process takes time and you want to avoid surprises, we'll call them, at the time of discharge, because it's really a dangerous time for patients, as you outpatient providers will know, and we want to make sure that we're giving ourselves adequate time to do that appropriately. Finally, working with a multidisciplinary team for the progression next phase of care is critical. So reviewing therapy notes, physical therapy and occupational therapy, they'll often make recommendations for discharge locations based on a patient's function. And keeping that team up to date on discharge readiness. This includes your case managers and your social workers and other people that help patients to be set up for success at home. Keeping them up to date, again, to avoid those surprises on the day of discharge, and discuss discharge plans on a daily basis with your teams. Many hospitals will have multidisciplinary rounds or some other function where you can get a hold of your entire team to make sure that you're progressing that patient to the next phase of care. And support system at home. Again, this is critically important for determining what patients have at home. So calling families to not only keep them informed of how the patient is doing medically, but also where they are within their discharge planning. Now let's look at discharge. For acute diagnosis and management, really this is where we think of what are the discharge criteria. We've touched on this a little bit, but really the discharge criteria is, are they able to safely administer their care with sufficient support to return home? And this is dependent on what their home situation looks like. And the other thing we want to emphasize is that patients don't have to be cured while they're in the hospital. It is very, very common, in fact expected, that a patient that comes in with, say, a viral pneumonia is going to have a cough for up to 4 to 6 weeks. That cough should not be gone by the time they leave the hospital. We just need to make sure that they're on the adequate road to recovery and able to do this, which they'll be able to do better in the outpatient setting. To prevent harm after reconciliation, again, our theme of medication reconciliation, this is one of the most critical times when a patient is leaving the hospital to make sure that their medications are reconciled correctly. I strongly advise you to look at the discharge instructions, read them yourselves. Many EHRs give that functionality, so you can actually see what the patient is going to have in their hand to know what medications that they're supposed to be taking. Outpatient communication is also critically important. So being specific about follow-up items. You all know this from working in the outpatient setting all the time when you receive patients from the hospital stay. It's really important to know what happened and what the inpatient providers thought was the most important thing for the next phase of care. Being clear about why medication changes were made. And then if a patient is going to a facility, oftentimes the only documentation that they receive is that discharge summary. So if and when possible, send that as promptly as you can, ideally before the patient even leaves the hospital, or sending it with them with their transportation. And progressing to the next phase of care, again, plan early. Do not wait for the day of discharge to coordinate plans. Doing that increases the risk of haste and errors. And finally, you can be a bridge. You can ensure a patient has PCP follow-up. The other thing you can do to be that bridge until a patient sees their primary care provider is follow up on the labs before the patient sees their primary care physician. If you feel like the patient needs to have a hemoglobin or basic metabolic panel checked in 2 days, but otherwise are safe to go home, it's perfectly fine to arrange for home health or for the patient to come back to the hospital to have those labs drawn, and you can certainly follow that up, again, being the bridge. And then calling the patient after discharge is another thing that's beneficial to check in to see how the patient is doing, to make sure that you've adequately transitioned them safely to the outpatient space. I'm now going to hand it over to my colleague, Dr. Brooks, who's going to walk us through some case studies.
All right, thank you, Dr. Anstat. I appreciate it. And we're going to move through some case studies now to really illustrate the way that these objectives of inpatient medicine play out in real life cases. These cases were pulled from both my and Dr. Anstat's recent experience in treating patients through the pandemic. Our first case, really focusing on acute care, with a 53-year-old Amazon delivery driver presenting to the emergency department with acute dyspnea and chest pain. She's found to have a submassive bilateral PE with mild right heart strain and acute hypoxic respiratory failure. She's been admitted to the ICU appropriately for close hemodynamic monitoring, started on anticoagulation, and after being stable, she's transferred to your service on the medical floor after 24 hours. She's really improved quite steadily, but she's still requiring 2 liters of oxygen with exertion to maintain her SAS greater than 90. As we said, she's been improving, but she's still needing some oxygen with exertion. What is your next step in management? A, keep the patient in the hospital for continued monitoring. I mean, she was only admitted yesterday. B, keep the patient in the hospital until her oxygen requirement resolves, as this is likely not a long-term need. C, ensure the patient has insurance coverage for oxygen, and if so, discharge her home, and her PCP can titrate off the oxygen as an outpatient. Or D, discharge the patient without home oxygen. It's only with exertion. It's temporary, and we don't want to overutilize resources. If you answered C, ensure the patient has oxygen coverage, and if so, discharge home, this is what a hospitalist would do. When we think through the other answers, again, thinking back to those principles that we've been talking about, we really want to discharge the patient home as soon as safe. And so regardless of how long she's been in the hospital, if she's stable and we can make sure that she has the appropriate care at home, we should really try to get her out of the hospital. Thinking about answer B, well, the oxygen requirement will resolve, but pulmonary embolism is physiologically different from some other conditions such as chronic COPD. We actually want to make sure that we support her and prevent her from having hypoxia, to prevent her from having long-term right heart damage. And so that's why D would not be appropriate. We really need to make sure she has the oxygen that she needs, but we also don't need to make sure she stays in the hospital until it's completely resolved. So for a take-home point, really think about how to discharge your patients as soon as it is safe for them to leave the hospital, and to appropriately support them at home. Moving to think about inpatient harm, we have a 75-year-old man with systolic heart failure who presents with dyspnea and 15 pounds of weight gain because he's been relying on prepackaged food. Unfortunately, his daughter usually cooks low-salt food for him, and she's been separated from him because of social distancing orders. On admission, a Foley catheter is placed, mostly for convenience because he requires a walker for ambulation and he's needing substantial diuresis. He's also put on telemetry out of concern that he may develop electrolyte abnormalities with diuresis, although these were completely normal on admission. On hospital day 3, he's actually been doing quite well. He's lost 10 pounds, and there's been a plan for possible discharge the following morning after transitioning to oral diuretics. Around 8 p.m., he's been agitated, complained of a lack of ability to sleep, and so your cross-covering provider ordered zolpidem. And then around 3 a.m., he awoke, disoriented, stood to try to urinate, tripped over his catheter, and then he struck his head on the telemetry monitor. On hospital day 4, he continued to have waxing and waning mental status consistent with delirium. The CT head was performed, which was negative for any hemorrhage. Unfortunately, his UA revealed a UTI secondary to his catheter. He then remained hospitalized for 5 more days, requiring treatment for his UTI, worsening delirium, and ultimately ended up being discharged to a nursing facility because of his increased stability rather than home, as had been originally planned. Thinking about the harms that could have been prevented, A, they couldn't. This patient was sick, they have worse outcomes, and bad things happen. B, do not insert urinary catheters for diuresis unless you are unable to get accurate I's and O's or patients are having skin breakdown. C, don't order zolpidem or other sedative hypnotics for elderly patients in the hospital. C, don't continue telemetry unnecessarily in patients with stable electrolytes and no unstable arrhythmias. Or E, discharge the patient sooner. We don't need to wait for a transition to oral diuretics before they leave the hospital. Let's go through these one at a time. A, it can. Many of these harms could have been prevented for these patients. And we really need to be very active in trying to prevent harm for our patients. So B, absolutely. Urinary catheters are not necessary for diuresis unless you're unable to get accurate daily weights or I's and O's, or the patients are having skin breakdown, or they have another clinical indication for a urinary catheter, such as urinary retention. In this case, it caused him several harms. First, Foley catheters contribute to delirium. They also contribute to falls. And then he also got a catheter-associated UTI. C, absolutely. Zolpidem and other sedative hypnotics are very dangerous for elderly patients, both at the outpatient setting and particularly in the hospital, where they're associated with increased rates of delirium and increased rates of falls. C, do not continue telemetry unnecessarily in patients who are stable. There are clear American Heart Association guidelines on the use of telemetry, and in patients with stable electrolytes and no unstable arrhythmias, then telemetry is not necessary for patients undergoing diuresis. E, certainly this may have been an option. You don't always need to wait for a transition to oral diuretics to discharge patients. Some patients who are very reliable and who have excellent family support may be able to do weight-based diuretic dosing at home. You may also be able to arrange for telehealth visits for diuretic monitoring, or even close outpatient follow-up in cardiology, heart failure clinics, depending on the resources that are available in your area. So our take-home point, the hospital poses many risks for harm, particularly the elderly, and it's really important for us to avoid unnecessary intervention. And just to highlight, these cases may seem contrived, but they are actually quite real. So this week, I have admitted a patient in this exact same circumstance with heart failure because of prepackaged food. And many of these harms that have happened, I've personally seen happen to patients. So this is a very real thing, and there are very real steps we can do to protect our patients. And finally, thinking about progression to the next phase of care. 65-year-old veteran is transferred to your hospital for an acute COPD exacerbation. Unfortunately, he did not practice social distancing. Unfortunately, he did not practice social distancing, and he continued to attend his regular meetings at the local VFW. On admission, he had worsening hypoxic respiratory failure with O2 requirement up to 4 liters when his baseline is 2. His chest X-ray revealed hyperinflated lungs, but no focal infiltrates. And he may be in one of the places that has plenty of testing and is testing everybody. And his COVID-19 testing was actually positive. On hospital day 3, he's been being treated with metered dose inhalers and oxygen therapy. He's been slowly improving, although he still has a little bit of dyspnea on exertion and intermittent wheezing. His inflammatory markers are getting better, and you think that he'll be able to be discharged in 1 to 2 days. On hospital day 4, you plan to go see him, but the COVID unit is all the way across the hospital from your typical unit, and so you decide to see him last in order to save you some walk time. So you go into his room at 11 a.m. He feels ready to go home. He's eager to leave. He's got his baseline oxygen requirement. His wheeze and his cough have gotten better. You take care to review his home medications. You send his e-prescription albuterol as well as his PRN cough medicine to your in-house pharmacy, thinking that this will be the easiest for you and easy for him to pick up on his way home. You carefully write his discharge instructions. You tell him about his quarantine instructions. You arrange for him to have his PCP follow-up. You feel pretty good about that. This is a safe and well-planned discharge. You tell him good luck, and then you leave the room. 2 hours later, you get a call from the nurse that the patient can't get home because he can't take a cab because he has COVID-19. He doesn't have a portable oxygen tank, and actually she prefers to get all of his medications filled at the VA because it's significantly cheaper for him. So you spend the next several hours faxing forms to the VA to cover his medications, you get respiratory therapy to see him so they can get a portable oxygen tank. And then still in the afternoon, because he doesn't have a ride, the hospital must arrange for ambulance transport, which at this point now can't happen until the morning. If you answered B, C, and D, you're right. So absolutely many of these things could have been avoided if we had been talking with our case management and interdisciplinary team daily. At both Dr. Amstad and my hospitals, it is absolutely true that a COVID-19 patient cannot get into a cab. And that if they don't have a ride in a private vehicle, they have to get an ambulance transport home, even if they are completely ambulatory. Talking with your case management and interprofessional team daily is really helpful to keep an eye on the shifting realities in the ground. Many of the times in a dynamic situation like a pandemic or any other disaster, the community resources that are available to patients can change on a day-to-day basis. They may take longer to access, or they may be unavailable altogether. And so really being proactive with discharge planning can help you keep ahead of the curve on that and make it less likely for you to get unwelcome surprises while you're in the process of discharging a patient. Asking the patient where they want their medications filled is very helpful. You can often send medications to pharmacies the day before so their family members can pick them up. I think many of us who don't work at the VA any longer know that the process of getting medications filled through the VA is particularly challenging at times. And that's the case for other institutions as well. And so really trying to do that kind of thing in advance will save you a lot of time on the day of discharge. And finally, if you see the patient earlier in the day, well, that gives you more time in the day before the 4:35 p.m. shutdown to really get these things taken care of so the patient can still go home that day. If you answered E, there are absolutely times where it may be appropriate for the pharmacy at your institution to sponsor medications for a patient if they don't have insurance, if they need a bridge prescription until they can get to a specific federally qualified health center, or things like that. And talking with your case management can help you identify the patients that may be appropriate for. But in this case, the patient has insurance coverage. We just needed to figure out how to get his medications filled earlier. So take home point, start your discharge planning on the day of admission and continue it every day of the patient's admission. That will make your day of discharge much smoother and actually a lot easier and more pleasant for both you and the patient. So to sum up, inpatient medicine really involves focusing on the acute medical condition. We triage it, we stabilize it, and we treat it. Throughout the patient's hospitalization, at admission, during the hospitalization, and especially at transitions of care, our goal is always to prevent harm to our patients. And then we are always thinking about how to progress the patient to the next phase of care. We want to plan early, we want to coordinate with our case management and professional team, and we want to actively bridge to outpatient care providers and to providers at the next phase of care. If you're looking for more training, as you may be coming into the hospital, there is a utilization management and triage decisions module that you can access through SHM. Additionally, the SHM Learning Portal has multiple COVID-19 resources that we would be happy to have you access. We really appreciate your attention for this module, and we really appreciate your efforts in moving to the inpatient care environment to help address the acute needs of our patients during this current disaster. We wish you the best of luck, and please stay safe. Thank you.